Hi, everyone. I think this is recording. Looks like it is. Okay. This is really weird. I'm giving this presentation by video because I am in clinic on Thursday, and so I won't be able to join you all. And quite honestly, this is my first run at it, and I don't have time to do it twice, so hopefully this goes okay and is efficient enough. I really wish I was with you all in person to help contribute to this presentation and answer questions and talk about solutions, but I'm in clinic on Thursdays, so I won't be there, and really appreciate Dionisia, part of the core project team for the Aurora Health Alliance Specialty Care Needs Assessment, who will be representing and can circle any questions back to our larger core group who has been doing this project. Also, was prompted to try subtitles on my PowerPoint, and so I'm sure many of the words will be incorrect, and I'm a fast talker, but because I am a fast talker, I turn subtitles on and hope that they are somewhat helpful. But let's go ahead and jump right in because I'm going to try to be as efficient as possible. I am Kari Mader, and I'm a family doc and an interested, passionate partner in Aurora who's really interested in helping to improve specialty care access. And so that's why I've been a part of this project team and why I'm talking to you all today. I'm also really passionate about thinking about the problem before we jump into solutions, particularly complex problems. So I really wanted to be able to help contribute to wrangling a really complex, longstanding problem in Aurora, so at least we could identify one next step. So with that, that leads to this. I love this, this Albert Einstein quote, so I always put it in presentations when we're talking about problems, that if we wanted to solve a problem, we would spend 55 minutes thinking about the problem before mapping solutions. We're actually going to spend a little bit more time mapping solutions, but the solutions are really a reflection of a really well thought out problem. So hopefully we are getting one step closer to that with this presentation today. So before we jump in, I just want to give a quick shout out to the core project team that's been involved in the AHA adult specialty care access study. This was focused on adults, won't talk about why, but that was what was prioritized. It's crazy because we started in this work actually 2 years ago almost. So it's sad how long it has taken, but we have been a volunteer core project team. And so we have done this as we can and as we could. And so it's taken quite a while. And it's why today there is this presentation, but we're still going to be a couple more months out from the final, just kind of pretty report. We're going to wait for our med student team who one of them, Eugene, has been doing this project as part of his longitudinal scholarly project, and he's on rotations right now. So he'll be helping to contribute to a report when he gets off of those. But Dionisia, myself, Allyson Gottsman, Eugene, Clayton Hoffman have all been a part of our core project team for the last 2 years. And then a list of others have filtered in and out to help, along with several analyst volunteers who have really helped us in the last 2 months to try to get this across the finish line for this presentation today. So thank you to everyone who's been involved. So let's go ahead and jump into our methods for this project. So just as a reference, the reason why we did this is myself and Dionisia were in a meeting 2 years ago, an AHA meeting where Colorado Health Institute had done this wonderful study looking at access needs for the state. And I remember distinctly that #1 need that came out was ophthalmology. And I just, as a provider on the ground in Aurora, was like, man, that just doesn't resonate with me. And I felt mixed about any kind of advocacy that would come like really focused on ophthalmology in Aurora if we were missing the mark. And that led to future conversations with others where we said, you know what, we really want to do something in Aurora to make sure we know what the key priorities are, because we all have limited time and bandwidth, as evidenced by 2 years to really get this study across the finish line. Or this needs assessment. It wasn't an official research study, but this needs assessment. We all have limited time and bandwidth, and we want to really make sure we are getting on the mark. And so we identified that we needed to do some primary data collection, or data collection that was focused on the exact question at hand, is what are the priority needs specifically in the city of Aurora, and so that we could identify some focus areas moving forward. So that's what led to what we're talking about here today. We developed a survey that we call the AHA Specialty Care Survey, distributed that to a comprehensive list of clinics. Can go into more detail. Dionisia can answer questions about this, but it was built from HCPUF, a list from HCPUF for Medicaid, and a couple other key informants that reviewed the list. We just sent it out as much as possible in lots of different ways to various practices and providers, and it was convenient sampling. Whoever responded was what we got. We did select, we sent to a wide range of clinics, any clinics that might be serving Medicaid. One of the first questions that selected out from the survey was making sure that people felt that people said they cared for patients in Aurora, or for Aurora residents that either were insured by Medicaid or uninsured. And so that was a self-selecting question in the survey to just make sure we were getting the right respondents. What was the structure? The structure had two parts. Part one was required, part two was optional. Part one asked basic roles, demographics, and then asked respondents to rank their top 5 unmet needs for patients with Medicaid or patients who had no insurance. And then it also asked a follow-up question if there was a self-selecting question before that asked if you cared for patients who were Aurora residents who were insured by Medicaid or those who were uninsured, and then they got the specific part of the survey, Medicaid or uninsured, depending on that response. Right. But in addition to unmet needs for both populations, it also asked top 3 needs that were easier to access, and also included the option to be like, there's nothing, everything's hard. And then there was one more question in the first part of the survey as well that really called out the issue of expensive procedures or diagnostic tests, specifically in the uninsured population, as that was going to be hard to capture in the prior just overarching specialty care ranking question. That was mandatory. And then we moved into a solutions category where there were some free response questions about key barriers and key solutions that have been tried or should be tried regarding specialty care in Aurora. And that was an open-ended response question. And then there was a quantitative response question where we used a standardized measure of barriers that have been identified nationally and solutions that have been identified nationally for both Medicaid and uninsured populations. We adapted a standardized survey that had been used in a multi-state study and used it for part 2 of our survey, so that we had both a quantitative and a qualitative portion of looking at barriers and solutions. And then for analysis, we really just looked at frequencies. And you know what, as I'm looking at this slide, it says means. We did not use means. We used medians, I think, for some of them. And then in order to make meaning of those top 5 priorities, 1 through 5, we looked at just overall total counts, a specialty was noted, and then also looked at, as kind of the gold standard answer, those priorities ranked. So we assigned a certain number or point based on if a number said number 1 need versus number 5 need, for example. So the number 1 need got 5 points, and the number 1 need got 5 points, and the number 5 ranked need only got 1 point, to try to create some sort of ranking system to think about the top unmet needs. And so we looked at both absolute, again, total amount of times a specialty was stated, as well as that ranked system to develop the emergent needs. And then for the open-ended responses, we had a group of coders, 4 to 5 coders who came together, and we identified emergent themes that were noted for both barriers and solutions, and combined those with the quantitative piece that we saw. And then during this time of the 2 years, there was increasing awareness around other, as we started to do this survey, we just started to hear about other various needs assessments that have been done at various levels. And so we layered in those into the findings just to add additional context. And I will say, in terms of methods, we viewed the survey as the gold standard. Like, these questions were specifically tailored to get at what we wanted to know, which was unmet need in Aurora from providers and care team members on the ground. And then we layered in the findings from these other assessments that have been done over the last few years to just add context and affirmation. I didn't let those findings dissuade from the findings of this survey. And luckily they aligned. which I'll tell you about. In terms of solutions and what I'm going to present around potential solutions for this work, I also took from the primary survey as well as some of the prior reports that have happened recently. One other, and sorry on this slide. So in terms of unmet need, there were two other Colorado-based surveys. One was by HCPF, where in 2019 they surveyed mostly the care managers in the various RAYs. So I actually pulled the RAY results from Region 3, which correspond to our area, to layer in results for this. And then there was a Colorado Safety Net Collaborative report that was a lot of Denver Metro clinics, but also safety net, non-FQHC safety net clinics in the region. But that was more Colorado based. And then there was an additional data set that we worked on from CU. CU's been such a wonderful partner in this, and looked at the wait lists for all of the CU specialty care clinics. And so just to highlight what that was, so we have evaluated the average wait times for new patient visit requests that occurred over a 6-month period, so the first 6 months of 2021, controlled for people that had an Aurora address. So looking at waitlist times for Aurorans. And then there were two different reports that we pulled from that to try to provide two different ways of, again, comparing and layering in additional evidence to this bigger picture. One was just absolute wait times for patients insured by Medicaid and the longest wait times, and looked at the top 10. And then also looked at wait times for Medicaid patients compared to commercial insurers to identify significant disparities. So getting into the survey results, because I'm already going to be short on time, is there were 54 respondents to the AHA survey. This was completed, by the way, by I think it was early 2021. We started collecting late fall. Dionisia can correct me. There were 15 different clinics represented who care for Aurora residents. Of those who responded, about 60% of those were from FQHCs in the area, but the other 40% non-FQs. About half were primary care providers, half were other care team members that are experts in referrals. And about 2/3 of respondents responded to at least some of the questions in part 2. Some of them only did the open-ended responses and didn't do the quantitative piece. About just under 40% did the entire part 1 and 2, which was really impressive and showed a lot of interest in this topic and lending their voices. So in terms of unmet need, that first part of the survey of the top ranked needs, big conclusion, not surprising, all specialties are an issue. For those 54 respondents, given a chance to rank the top 5 unmet needs for Medicaid, every single specialty on the survey list, which was a very long list, was mentioned at least once. So that's so to everyone, there is need. And the same was the case for uninsured patients, with the exception of there were 3 specialties that weren't mentioned among the top 5. That was including obstetrics, neurosurgery, and podiatry, but every other one was named as well. And what I will say is that most urgent unmet needs for Medicaid and uninsured, based on these survey results, the top 5 are a little different for Medicaid and uninsured, and I'll quickly run through those. I don't want to get too in the weeds. I just want to get this out there, and then you guys can look at the results in more detail. The top emergent needs were different, but overall, the next 5 after that, there is a lot of overlap between Medicaid and uninsured, which is a nice alignment for thinking about advocacy. So for Medicaid, the top 5, looking at our ranking system and just pure absolute frequencies for Medicaid, number 1 was neurology, 2 was rheum, 3 psychiatry, 4 urology, 5 endo. And what I will say is neurology was definitely number 1 when you look at absolute total number of times something was mentioned, as well as in the ranking. The next 5 were orthopedic non-operative, cards, orthopedic operative, pain management, and substance use treatment. I will say that when you get into the middle range, so 5 and 6 were actually the same numbers, so endo and ortho non-operative, and 8 and 9 were tied as well in terms of numbers. So the numbers start to have much less differences when you get into these, and this is why I included all 10. I think even if we just started somewhere around the top and started to tackle some of these a little more intentionally, if they aren't already being addressed already, that would be a win. But neuro definitely came out as a top need. And then when we started to look at the CU waitlist data, and I'm so sorry, I realize like the clarity on this color isn't coming through right as I see it on my computer. But when we started to look at the CU waitlist data and the specialties with the absolute just pure frequency, longest wait times in the CU system, these that are highlighted came out and they were in the top 10. So endocrinology was number 1 and neurology was number 3 in the CU system of absolute wait times, both with an average or median wait time of more than 70 days. And then rheumatology, cardiology, and pain management get into the lower ranks, including, I think cardiology is number 8 or 9. So still in the top 10 specialties with longest wait times in the CU system. But definitely lower wait times than in the 70-day range. And then if you look at specialties within the CU system that have significant disparities and statistically significantly longer wait times than commercial insurers, we add a couple more in there. So urology and then orthopedics non-operative. So just a note about orthopedics non-operative, this is sports medicine in the CU system, which traditionally is non-operative interventions, but also operative interventions do get mixed in that. So number 8 of ortho-operative might be in there. So it affirmed urology and orthopedics non-op, also cardiology, pain management, all do have significant disparities. And I'm looking at my notes right now and I can't remember. Pain management, sports medicine, urology, and cardiology all have significant wait time disparities from commercially insured. And then, so this is my big slide where I'm layering in the additional data sets. So if you look at the RAY findings from Region 3, 3 of these were affirmed as key priorities by the care managers in Region 3 in 2019. So those are the ones in blue. So rheumatology, urology, and endocrinology. I will say that the RAY back in 2019 also identified GI and derm, but both of those were on the list. It's just weren't in the top 10 in this study. So I'm again considering this study and this survey is kind of the gold standard, the closest approximation of the truth, with then these additional studies kind of layering in affirmation. And so it is interesting that the RAY findings still fell within the top 5 on this study. And one more is the Colorado Safety Net Collaborative, which was not Aurora specific data, also prioritized neurology, urology, and orthopedics. It's interesting, neuro really comes to the top in a couple different data sets, but also was one of those that also layered in GI. So GI was prioritized in the Colorado Safety Net Collaborative, but again, not Aurora specific, but it was also included in the RAY study, which was kind of region specific for Aurora. Just a note is that psychiatry is on this list as number 3, and it makes sense that it wouldn't be affirmed in the CU waitlist data as the main Medicaid provider for psychiatry as Aurora Mental Health, and so that wouldn't be affirmed on this list. I'm also like seeing right now that waitlist is saying waitlist in the words on the bottom in the closed captioning. Okay, so let's talk about uninsured next. So top 5 for uninsured, as I mentioned, the most emergent unmet needs on this survey for uninsured did differ a little bit. So cardiology was number 7 for unmet need for Medicaid and was number 1 listed for those who responded for uninsured. But then the other top 4 were a little bit different. And what I would say is this is inserting a provider look on this, but these potentially could be more all very expensive or operative based specialties. So oncology, very expensive treatments, operative ortho, general surgery, and potentially GI, if you're thinking about procedures. The next 5 though really aligned with what was already seen. So neuro, urology, endocrine, ortho, non-op, and pain management. Things that are missing from this list that were on the prior one were psychiatry and rheumatology. And so just to highlight what I just said, actually, so the things highlighted are the ones that were already found on the prior list for Medicaid, with the exception of, I actually forgot to highlight number 3, ortho operative. But only one take at this, so that's what it's going to be. So number 3 should have been highlighted as well. So those are the overlap. So the one other unmet need question that was on part 1 of the survey was that one about expensive tests or diagnostic procedures. And so this part of the survey actually potentially highlights some of, if you go back, some of those unmet needs in the top 5. So I mentioned that maybe GI might be more procedure-based, I'm not sure, but when, and cardiology. But when we asked this question of what are your, if you could name 3 of your top 3 unmet needs for expensive diagnostic tests or procedures for uninsured populations, the most common one was endoscopy, colonoscopy. It was mentioned almost double the amount of times than anything else. But definitely emergent. Second most common was cardiac testing, with all of these that are listed here. And then number 3 was expensive scans that are needed for being able to seek further treatment. There are really great quotes associated with all of these things that will be available in the final report. So endoscopy, colonoscopy might be explaining that number 2 priority a little bit for GI, as well as actually and cardiology is number 1 on uninsured. And MRI, CT scans were definitely listed as an important precept to oncology evaluation. And so those might be related, but that's limited free response. And so that is just my bias in interpreting these results. So looking at the lowest 3 needs and what we're doing okay with. So what, as I mentioned in the beginning, all of the needs were every need in terms of Medicaid was listed among the top 5. So I would say, as we know, this is a widespread issue, but there were 3 emergent specialties that were listed among the least problematic for Medicaid and uninsured. They were the same. So obstetrics, cardiology, and general ophthalmology for both, just in a slightly different order for the uninsured. And of note, general ophthalmology was listed as the emergent need in that CHI study. And so it was just really interesting to see that that came out as one of the lower ones, which is what was one of the reasons for doing this work. So as you will notice, cardiology is on this list. It was also on the emergent list for unmet needs. So I don't know, we don't know, probably needs further study about why it's on both, but it definitely was on both. And I think in the preliminary results last spring, we did start to highlight that. But as we dug into the data, that was definitely true and not sure the reason. So overall recommendations, if you're looking at priorities from the part 1 of the survey, would be this list and some prioritization. I would say neuro again came out on top. But the other ones, definitely, if we started to work on any of these, it would be a big deal. I will highlight that a couple of these, like orthopedic non-op care, pain management, substance abuse management, are things that can potentially be done in primary care. With the exception of, so this is an important overlapping list that would still start to meet needs in Medicaid and uninsured populations, with the caveat that uninsured might need some additional attention towards some of those procedural areas highlighted in the circle of gastroenterology. Maybe that's the endoscopy, colonoscopy issue. Maybe it's something else. Oncology and general surgery. Oh, and the caveat, if I removed cardiology from the list and put it as a highlight, because not sure where, I mean, it definitely is a need. It definitely is something that emerged as a topic area that is being addressed well, and maybe presents a really great area of opportunity to look at best practices and what's happening there in order to inform more solutions than we're talking about here today. I also realize I am way over time, and I'm going to send an email to ask the specialty care task force for more time for our presentation than we have allotted right now. So where do we begin? I'm going to quickly try to rush through talking about understanding the barriers and mapping the solutions, because we didn't want to just talk about this big problem and not talk about solutions. And so what the prelude is, I think we have some good steps that started to emerge. So first, The underlying threads, which the most robust piece of this data was the qualitative open-ended response data. And then the quantitative really affirmed what we saw in the qualitative. But there's just 4 quick context setting things I want to review first. One is that all of the coders, we agreed that what we read throughout the whole results is that the system is broken and it really doesn't function well for individual patients. That's why we're all here. I think we know that. And because of the complexity of the problem, though, it's going to require a multifaceted solution. I will note that there were very specific comments throughout the open-ended responses that noted that the state Medicaid program, UC Health, Aurora Mental Health, and Medical Center of Aurora, as 4 initial stakeholders, really need to be a part of the solution. There was a major theme in the findings about the struggle of providers on the ground who are really trying to provide good care for these patients. And if I were to put a word to that I have learned in the last few years, that would be that moral injury of doing this work. And so just to speak to their experience and hold up just the great resilience of providers and team members, care team members, referral managers on the ground who are engaging in this work. And then last, there was a big theme around that, definitely highlighting where this is working and the positives is going to be an important part of the solution. Okay, so specific barriers for Medicaid and uninsured. So there were some that were emergent for both, and then a couple that were unique. Don't need to talk about this much. Specialists don't accept a lot of Medicaid or uninsured patients. We know that. We don't really know why, but there have been other studies that have explored this complex issue, including a CMS study that could be used as part of the solution generation. There is significantly limited access for those that do accept Medicaid and uninsured patients, except for obstetrics. And we know that because obstetrics did come out as a key least needed need. It's an issue, but it's definitely not among the priority. And there were definite open-ended responses that affirmed that for everything except obstetrics, things seem limited, but OB is okay. Third context, which is the most, the richest piece of the barriers that informs the solutions, is that the current specialty care environment in the Aurora is really complex. It's challenging to understand and navigate for patients and people who provide specialty care referrals, and it's not transparent. So there were a number of challenges noted, including long wait times. This was specifically only seen on the quantitative piece. Transportation, anything that doesn't have an asterisk on this slide was seen in both the quantitative and the qualitative results. So transportation, accessing care that's far away, having to schedule really far in advance, which then makes it a problem for patients because it's hard to know what your schedule is going to be 6 months away, as well as language barriers and cultural sensitivity. That being able to send patients to a culturally sensitive provider is a challenge and came out clearly. And then specifically for uninsured patients, there is this system complexity that comes out as well when they're needing to go around a community to get the necessary diagnostic tests from multiple places in order to then even get a referral. And so that came out as a specific additional level of complexity. Just to show you a couple quotes from this work, all clinics are full for Medicaid patients for the year, no new patients accepted. And then, so that just sums up a bunch of those initial themes, those 2 around limited access or no access. And this is a long quote, but I'll read it out loud and you can read it. But having the time to individually advocate for patients to get urgent care when they need it, there's really no time for this. Helping patients address their barriers to getting the appointment scheduled and then physically going to the appointment is hard. They don't even know how to navigate the complex system to get an appointment and often have transportation issues getting there. And then there was specifically with psychiatry, it's really tough to coordinate them getting prompt access through Aurora Mental Health when they're near crisis. And I meant to be intentional to pull out any names of entities. So I'm sorry I left that one in, but we all know we're doing the best we can, but there's always opportunities to improve. So third, just example quote, trying to highlight the different themes, having them follow up with appointments that are scheduled months in advance is hard. And then transportation, time off work barriers for the patient. That's looking at that transportation issues and opportunity cost of needing to seek care and how that's hard for people. So there were 2 specific themes as well for Medicaid and uninsured. I started to hint at this, but for a dominant theme among Medicaid specialist providers is that for specialists that accept Medicaid, there is a cap that limits access, and that cap was noted multiple times to be confusing, not transparent among the larger network, and that makes it hard to help patients get the access they need. So a couple quotes just to highlight this, because this was really an emergent concept, is that there are caps on how many Medicaid patients they can see for each specialty, and it isn't transparent. It's very difficult for us to know if someone's accepting Medicaid or not, as it often changes, and it is difficult to find out. Blank claims to take Medicaid, but then denies referral due to being at capacity. We don't have many options for Medicaid patients being referred out. Sometimes we have to tell our patients to follow up with Medicaid, so state Medicaid, and see if they're able to assist them with location. So that just explains that, like, providers and specialists and referral specialists, I'm using that term broadly to include anybody who does referrals, don't even know. So they're like, can you call state Medicaid to get that access? So it just highlights that challenge navigating the system. Dominant theme for uninsured is that it's all the prior things plus cost. And this is not surprising. Cost is the major issue for uninsured populations because healthcare costs a lot of money. And then specifically within that, transparency around cost is a challenge, and they often forego care just because they can't figure out the number that it costs. And that contributes to barriers of specialty care at each step of the way, including getting those tests across the system and community that are needed to even access a specialist. Of note, cost did come up on the quantitative side for Medicaid as well, but it was not in the qualitative findings. So just a note about that it's a little unclear if that truly is a major barrier for Medicaid patients as well, but it definitely came out among uninsured, not surprising. For uninsured, I'm so over time, too expensive, no types of payment plans at times. Colon cancer, this was just a quote that hit me. It hit our team, analyst team. Colon cancer screening beyond a FOBT test is a joke for uninsured patients. We have little to no options for diagnostic colonoscopy for this population. Joints are also a challenge. The largest barrier is lack of cost and lack of cost transparency. So getting at this theme, my patients can't afford to go to X institution if they are uninsured, and I can't even tell them the cost if I wanted to. Any expensive diagnostic tests and procedures are a huge issue and make it virtually impossible. Knowing the actual cost is a problem. If we could have that, that would be helpful and allow the patient to make a decision, but that is not available. And then this quote highlights some specific high yield potential interventions for testing. Okay, that makes the problem big and complex, but we can have a complex adaptive solution. So due to the complexity of the problem, the solution must be multifaceted and adaptive over time. And that was a large concept that came out that we agreed that this context setting statement needed to be before we talked about the solutions that came out. Our analyst group decided we needed to make sure we said that. So this is normal and expected. And hopefully on the next few slides, we'll highlight opportunities and for next steps. So one quick comment is there are a lot of even local Colorado places that have started to figure out how to do this. And so as we start to approach certain solutions, learning from bright spots is important. And this list is not exhaustive, but just threw a couple on here. I won't highlight it, but you can read the slide and we can come back to this, or you can come back to this. That includes IT, certain models of organizing, and certain learning groups like the KP Ascent Network right now. So just a couple comments that led to the solutions I'm about to present that underpin some of those, but every solution that is going to be presented was noted in the qualitative open-ended data or in the quantitative piece. So being transparent about access and developing a central tool for care managers and providers to reference to see if someone is accepting Medicaid at this time. That was a big thing that came out. E-consults should be expanded and work really well and should be paid for. So that has care model implications and policy implications around payment reform. And then a dedicated specialty care coordinator who has relationships would be helpful, knows what is going on with all the clinics, paired with someone or maybe the same person specifically as a patient navigator and helps with those social determinant of health resources and issues that relate to lack of access to care. And then there was one provider or respondent, one care manager, somebody that blasted out a ton of great solutions: mobile unit, telehealth, labs and testing order done at the primary facility, the primary care clinic, having the ability to phone a friend would be important, e-consults, offering specific specialty clinics at FQHCs, and then allowing other FQHCs or other partners in the network to access that, even if they're not from the same clinic. And then potential financial models, looking at specialty care clinics using more APP partnered with physician models in order to increase access to specialty care and have a little bit more of a financially sustainable model. So the first most emergent step, I will say, is there's, as we started to look at solutions as our coding and kind of analyst group, it was actually kind of overwhelming at first. The key barriers were definitely emergent, but the key solutions were not. And it was just, we were picturing a map in our mind, with the exception of this first step. So it was very clear that if we're going to make any progress, a transparent network map is what we're calling it, of specialty care access in Aurora is needed. And that was definitely heard multiple times in the comments. So an action step would be creating a collective list of what is available for Medicaid and uninsured patients. And as we build that list, we, meaning, I don't know if I'm going to be a part of the solution, but whoever takes this on, working with the individual specialists and institutional partners to understand specifically capacity and the policies that underlie that, with no judgment, just at least get them written down. And to build this network, a context setting thing is that some dedicated staff for network building will be essential, and maintenance to keep that as a living document, and probably some sort of tech solution. And that was mentioned in some of the comments too, with a good example being what's been happening in Boulder potentially. Beyond that, there's some categories of additional solutions. I'm not going to highlight all of these, you guys can look at this, but there's a robust set of potential categories of solutions. This was just one way of categorizing it, and this was informed by the results of the study, plus what was the solutions that were provided in the Colorado Health Institute report from 2019, as well as the Colorado Safety Net Collaborative report that also noted solutions. So this little map here was built from that and could definitely be edited. But I'll just say any of the solutions need to be in the context of robust care coordination. That was a theme. And then there's these categories of potential financial models that were mentioned. There's, under this bucket of collaboration, is this idea that everybody, once the map is built, calling institutions and clinics in to be a part of the solution and at least contribute something. A bucket of policy around payment reform for e-consults, potentially repealing statutory limitations on immigrant care was mentioned, the need for governmental funding for specialty care, accountability with metrics, and then a bucket of communication solutions, as well as then specific specialty care models. So won't talk about all of these, but specific quotes can go into this, but this looks like a pretty nice map of and a place to start, as long as we start with the top box. It seems like we cannot do anything else very effectively unless we start with the top box, which is building that network that's transparent, which will need people and some sort of IT infrastructure. Even if we just had a network with robust care coordination, that would be a really big step in the right direction. And then if you wanted to start getting into specialty care models and financial models, you could do that with a lens toward those priority unmet needs we talked about, starting with, for example, neuro. And one thing I couldn't highlight, because I'm not tech savvy enough, is the fact that there is work in these areas already. For instance, payment reform for e-consults, as well as tons of e-consult work going on in Aurora, and we already know that. So next steps, I already presented some, we presented some, we're going to leave it to this group. I'm so sorry I went over. And this is just a quote that I love to live by, and I just wanted to add to this. I think it's when we talk about complex issues, it's nice to remind ourselves why we're doing this work and the hope. And I know that a lot of you listening, even though I'm like staring at myself, think about concepts like this as well. But I love this quote from MLK, is that we make a career of humanity, committing ourselves to the noble struggle for equal rights. We'll make a greater person of ourselves, our collective we, a greater nation of our country, and a finer world to live in. And I am just appreciative for all the core working group members that have contributed over the last 2 years to try to help our working group move forward with some better data. And I am appreciative to all of you for listening and contributing to this work as well, so that we can forge forward in that struggle for equal rights and specifically equal access to this healthcare we all need and that Aurora needs in order to be healthy. That's it.